Hi, this is Raphael, and welcome to Ask Me Anything for today, the 30th of October, 2020. A couple of public service announcements today. Firstly, if you don't know already, this segment is available as a podcast, and you can download it on your favourite podcast app, including the Apple Podcasts, Spotify, Google Podcasts, and pretty much every other platform in the world. And that way, if you prefer, you can just listen whilst you get on about your daily tasks. Secondly, I have another podcast with my friend and colleague, Chloe Bunter, called Pilates Elephants. And Pilates Elephants is a different format to this podcast. Basically, it's a completely spontaneous and unrehearsed conversation that Chloe and I have every week about the elephants in the room in the Pilates world. So many commonly held beliefs that are actually myths and misconceptions, and we deconstruct them week by week. Warning, language alert for that one. And finally, final PSA, public service announcement for today is our clinical diploma, our diploma of clinical Pilates at Breathe Education is now open for January 2021 commencement. Enrollments are now open, and that course is for you if you're a Pilates instructor, if you've been graduated for some time, and if you really want to learn, like really learn the body and how to use that knowledge of the body in the context of a biopsychosocial approach to pain, to help people with pain, injuries, aches, medical conditions, etc., through clinical Pilates. So you will find that in the links under this, whether it's a podcast or whether it's a video that you're watching. In the description, you'll find a link to all those things. So straight into the questions now. Joe Carey says, AMA questions, considerations for a client returning from a mastectomy, single in this case, no reconstruction at the moment to consider, without further treatment, e.g. chemo or radiation. Or go into drug effects considerations, as I know that adds another whole layer of the effect, e.g. I have clients who are super sensitive in their hand joint, especially thumb, post-treatment. So, Joe, for clients with or surviving breast cancer, the general recommendations, according to the American College of Sports Medicine, are to return to exercise as soon as possible post-surgery, and that might be up to 8 weeks because sometimes people undergoing cancer treatment take longer to heal. Sounds like that may not be the case with this lady because she's not undergoing chemo or radiation. So basically the regular post-surgical guidelines apply. So that would be, basically medical clearance from her surgeon, but, generally around the 6-week mark. And the considerations there would be, closed wound, minimal swelling, all of that kind of stuff. But that's up to the surgeon to give clearance on when exercise is okay. And then the exercise considerations will just be, firstly, just general post-surgical rehabilitation. So she's going to have lost range of motion, strength and proprioception in that limb. And so you'll need to work on all three of those with her. And range of motion goes in the shoulder, goes in 6 kind of planes of motion or 6 degrees of freedom. So the arm, you can lift your arm straight up in front, that's shoulder flexion. You can reach it out behind, that's shoulder extension. So she needs to work on range of motion and strength in both those directions. Then you can lift the arm out to the side, that's abduction. You can bring it down and across the midline, that's adduction. So she needs to work on range of motion and strength in both of those directions. And then finally, you can rotate the shoulder out and you can rotate it in. So external and internal or lateral and medial rotation. And she needs to work on range of motion and strength in both of those directions as well. And so initially, once cleared by the surgeon, I would suggest start with separating the range of motion exercises and the strength exercise. So do kind of passive range of motion. She can hold like a broomstick in both arms and use her good arm to kind of push or lift the operated arm into maximum stretch position. She can do reps, or she can just do a held end range for 30 seconds to 2 minutes. And I would do that, probably every day if she's got the stomach for it. It should be a bit painful, shouldn't be agonising, but it should be fairly uncomfortable. And then separately do strength work, because her strength work will probably be in a smaller range of motion, because she won't have the strength through range to combine both yet. And then as she gets back towards full range and her strength starts to increase, then you can start to combine those strengthening and mobilization exercises. So that's it's just essentially a pretty straightforward rehabilitation protocol, and rehabilitation is nothing but the process of restoring strength, restoring range of motion, and restoring proprioception or coordination. So you need to practice all of those elements. The second consideration will be that, or may be, that she may have, if she hasn't had a reconstruction yet, she may be very self-conscious of her appearance, and so you'll have to read that or negotiate that with her. She may not be, but being sensitive to that, I'm sure knowing you, I'm sure you will be. But basically, that could be things like, well, maybe not giving her a mirror to look in when she's doing it, or maybe facing her away from other clients when she's opening up her shoulder joint or whatever. And the third thing is, at least initially, may be painful for her to weight bear on it, like lie prone. But you can probably get around that by lying her on a foam roller or arc barrel or something to do any prone work that you want to do. So hope that helps. And in terms of drug effects and considerations, so, number one side effect of many cancer drugs is, or number 1 and 2 are fatigue and nausea. So those are just things that you work with in terms of, you work with what you've got on the day, people's energy levels, their ability to concentrate, etc. But the things that you mentioned before, like clients who are super sensitive in their hand joints, especially thumbs, well, I'll just, work within tolerable pain. So, if they can tolerate it, great, just keep punching through. And if they can't, well, figure out an alternative movement that's going to work, similar muscle groups or a similar range of motion. Instead of gripping with like a power grip where you grip, with the thumb wrapping over the outside of your fingers, you could grip with the thumb and the fingers on the same side of the bar or the strap handle, which might, alleviate pressure on the thumb, or just play around with different grips in order to find, what is least uncomfortable. I would make an effort not to dwell on it and only sort of find modifications, for the exercises that are particularly intolerable for the client, and don't make a big deal about it. But if it's, if it's a big deal for them, then those are the modifications I'd suggest. Hope that helps. Vicky Gallagher says, "Hi, Raf. Can you please let me know if you've lately had a question around Pilates for MS, that's multiple sclerosis? I think you covered this topic, but I can't seem to locate it and would like to listen to your views around it. I've just heard that one of my childhood friends has been diagnosed with MS. Thanks." Vicky. Vicky, I don't think I have done one on MS. We did one on Parkinson's a couple of weeks back. So multiple sclerosis is, we don't know exactly what causes it, but most researchers agree that it is some combination of an infection, an autoimmune response, and genetics, where basically killer T cells, which are part of your immune system, cross over the blood-brain barrier and enter into the brain and attack your own nervous system. The myelin sheaths around nerves in the brain, which are basically the insulation of the nerves, which helps the nerve conduct signals very fast. And so when the immune system attacks those myelin sheaths, that can interfere with nerve conduction. So when you interfere with nerve conduction, you get a symptom, widely varying symptoms depending on the, what that nerve does. So if that's a nerve that, innervates a muscle, well, you're going to have reduced ability to contract that muscle, probably reduce control of that muscle. If it's a sensory nerve, you're going to have, reduced sensation or altered sensation in that body part. If it's a nerve that, feeds back temperature, you're going to get weird temperature sensations. If it's a nerve that's involved in cognitive function, you're going to get changes to cognitive function. You might get symptoms in relation to hearing or vision or speech, wildly varying symptoms, because the nervous system essentially controls every other system in the body. So when you have an issue with the nervous system, which is what multiple sclerosis is, the symptoms can be highly variable. And there are four types of multiple sclerosis, but the two basic types are, of which all four types are one or the other. The two basic types are called relapsing remitting, which is the majority of people have relapsing remitting MS when they're initially diagnosed. So it's typically women between 20 and 50 who are diagnosed. Women are like 3 or 4 times more likely than men to get it. And relapsing remitting is a type of multiple sclerosis where basically there are periods of incapacitation or periods of disease activity where symptoms come and then interspersed with periods of remission, where the symptoms go away and there's either partial or complete absence of symptoms. And when the symptoms return again, which they will, they may return in the same place or they may return in a different place. So people can, get initial symptoms of, visual disturbances or auditory disturbances, and then they might get tingling in their feet the next time or loss of control of their fingers the next time. So the symptoms can vary sometimes, within one person. So that's relapsing remitting. And then typically after somewhere between 10 and 20 years, relapsing remitting MS progresses to progressive, it's called secondary progressive MS, which basically is a slowly progressive form. So basically you stop having the remissions and it just gradually gets worse over time. And by the 20-year mark, something like 90% of people with relapsing remitting MS progress to secondary progressive MS. So there are several drugs that can slow the progression, particularly of relapsing remitting MS. So, that definitely needs to be managed by a neurologist, a specialist in MS. And as to exercise, well, exercise has been shown to be hugely beneficial for people with multiple sclerosis. It probably doesn't do anything for disease progression. So it probably is not going to slow her disease progression, but it definitely will improve her quality of life and prevent her getting other diseases related to inactivity like obesity, high blood pressure, diabetes, heart disease, etc., mental health issues. So exercise is fantastic. And even people with highly progressed MS, even people with severe disability due to MS can still get benefit from exercise and still improve their cardiorespiratory fitness. So the general recommendations for people with MS for exercise are the same as for everybody else, but you just have to work within their exercise tolerance and capacity. And probably the biggest single issue that is common across people with MS is heat intolerance. Part of the nervous system's job is to regulate heat, body temperature. And so in MS, typically people have real trouble with thermoregulation, regulating their body temperature. So, keeping people cool when exercising is a really good plan. Use fans, use air conditioners, use ice packs, have them clothed in clothing that allows them to remain cool, etc. And typically, if they do overheat during a session, it may exacerbate their symptoms transiently for less than 24 hours, and that is to be avoided. But it's not going to permanently alter the course of their disease. It's just a transient increase in symptoms. But the best plan is keep them as cool as possible. And the other symptoms can be diverse. So people can have cognitive deficits, people can have, balance issues, strength, flexibility. And so basically you just work within whatever her particular symptoms are. And if someone has balance issues, you can improve their balance by practicing balance activities, but just do it in a way that it's safe so she's not going to fall over, she's got something to grab onto, or you're there to help her or whatever it might be. And so it's basically just within her physical capacities, including her energy and fatigue state and whatever. It's going to vary from day to day. So just every day you're going to ask her, how are you feeling today? Are we good to go? Is there anything I need to know about? How's your balance? How's your strength? How's your flexibility? How's your mental fog? And just try and keep her as cool as possible whilst exercising. So hope that helps. Natasha Useldinger says, hey, Raf, how should I program for someone with a fused spine? So spinal fusion is a surgery where typically given to people with scoliosis, very severe scoliosis, and with some other spinal injuries, so maybe someone who had multiple spinal fractures or a stenosis or something like that, where the surgeons basically implant rods, usually titanium rods, anchored to screws, a pair of screws in each vertebra. So they might fuse, two adjacent vertebrae, say your L4-5 might be fused, or they might fuse your whole thoracic spine or your whole lumbar spine or your entire thoracic and lumbar spine in the case of a very severe scoliosis. So I don't know how much this person's spine has been fused, but basically once your spine is fused, those joints are no longer joints. It's now a single unitary, structure, so it's not at all bendable. So now instead of a lumbar spine or a thoracic spine, whatever, they've basically got a femur, a thigh bone that runs up their spine. So it's not bendable. You can't train spinal flexibility in somebody who's in the fused region of someone's spine who's got spinal fusion. And so, things that would be more difficult for that person in daily life, are things involving bending. Like, so when you do up your shoelaces or put on your pants at the start of the day or get up out of a chair, you have to bend you bend your spine as part of doing that. If you put the seatbelt on in the car, you twist around and rotate through that. So, your client's going to have trouble doing those activities. So you can help her compensate for her lack of spinal mobility by increasing the mobility in her other joints. So if you can improve her hip and shoulder mobility, that'd be awesome. Parts of her spine that aren't fused, if any, improve the mobility there. And just aside from that, do everything. I mean, you can still do abdominal work, but obviously no flexion because she can't flex if her whole spine's fused. But you can do planks and knee stretches and, she can probably even do things like teasers, although she won't roll up smoothly. She'll kind of go up and down like a plank. So I would just challenge her pretty much like a normal person, but just bear in mind she can't flex, extend or rotate in the area that's fused, and thus work on extra mobility in the adjacent joints and challenge her abs and back muscles and side muscles and whatever in, the neutral position that she's fused in. So I hope that helps. Kate says, hi Raphael, hope you're well. I have a question for AMA. I graduated from Breathe in 2014 and now teach a lot of older people in the UK. Shout out to all the older people in the UK. Wondering what the latest research is on osteoporosis and loaded flexion, i.e. roll-ups, roll-downs, spine stretch, etc. Many thanks, Kate Langton. Now, I'm going to smush this together, Kate, because I have essentially the identical question from Magda in Adelaide. So Magda says, osteoporosis, particularly related to menopause, it's known that load-bearing exercises are important and beneficial. Also, it's known or advised to avoid flexion. When I read the recommendation, avoid flexion, I'm a little concerned after anyone coming to Pilates group sessions, as flexion is a staple in every session. I'm wondering how strict one needs to be with flexion. Even for a mild, e.g. T-score of minus 2.5, should one avoid all flexion? A roll down or a roll up in Pilates is a flexion, even if we don't load with weights or springs. So Also, some research indicates that extension or isometric exercise seems to be more appropriate for patients with postmenopausal osteoporosis. I've not found any clear explanation, and I'm wondering, why is extension good? Great question, Magda. Great question, Kate. So basically, osteoporosis, osteo means bone, porous means there are holes in it, stuff can leak through. So osteoporosis is where the bones become more porous and less dense, in other words. So everybody has some kind of gaps in between the tissues inside the bone. In osteoporosis, those gaps are enlarged, so there's less bone tissue in there. And we typically measure osteoporosis with T-score, which is just a measure of bone mineral density related to basically the population mean, the average bone density, and how many standard deviations above or below that you are. So basically, one standard deviation, now think I'm going to be about right on this, but basically one standard deviation is the distance from the mean where 70% of the population are. So basically, just say your bone density was 100. Well, if you go to plus or minus 20 units, so 80 to 120, let's say 70% of all people your age are within that range. So that's one standard deviation if 70% of everybody falls within that range. Two standard deviations, something like 90%, I think, of people fall within it. So osteoporosis is diagnosed when someone has a T-score of minus 2.5 or more. So in other words, you're 2.5 standard deviations below the average bone mineral density for somebody your age. So that is like, you're in the bottom basically 5% of, bone mineral density for your age. So I would say the first thing there, Magda, is a mild T-score of minus 2.5. I would say that's a fairly significant T-score. That's definitely in the osteoporotic range. And so I would avoid loaded flexion. So yes, so now to the question. All right, so for osteoporosis and flexion, so the recommendation for osteoporosis, and particularly postmenopausally, women are more prone to this because estrogen plays a role in the calcification of bone. And so after menopause, there's less estrogen in the system. And so it's harder for women to deposit additional bone tissue. Now, it has been shown and replicated, and the current guidelines recommend that high load, high impact exercise is optimal for increasing bone mineral density in postmenopausal women with osteoporosis. So I would, look at basically exercise where somebody is doing 85% of their maximum or more. So in other words, an exercise where they can do 5 or fewer reps. So if they can do 10 reps, it's not heavy enough. So where they can only do 5 reps or 6 reps, say, and they can't do more than that, that's heavy enough. So imagine push-ups. A lot of 60 or 70-year-old women couldn't do more than 5 full push-ups, so that would be heavy enough. Maybe if they can't even do 5 kneeling push-ups or can't do more than 5, that's heavy enough. One-legged squats, lunges, full long stretch, things like that. So think, strong exercises where they can do 6 or 5, reps maximum, and think roughly neutral spine. Don't get too, finicky about it, but, keep them basically straight. And the reason is when it hasn't been shown experimentally that this is the case, but this is the caution basically, based on expert opinion that you see in the guidelines, and basically no one's game to do the study to test whether it's true or not. So basically when you load the spinal, the vertebrae in flexion, the 2 adjacent vertebrae, their front tips come towards each other, and thus you distribute the load within each vertebra more right towards the front of the vertebra rather than sharing the load right across the whole vertebra. You distribute the load more towards the front of the vertebra, and that predisposes people to what's called a wedge fracture, where the front of the vertebra basically collapses. And so, yeah, like I said, it hasn't been shown experimentally that is in fact correlated with more injuries, but it's basically, most people who know about it tend to suppose that it is. And thus, it's no one's going to get ethical approval to do that study. So it just goes in as an expert opinion in the guideline. Now, so what constitutes loaded flexion? So, well, don't think about external load. Think about load on the spine. So when you do a curl up, like a roll up or a teaser, something like that, you use your abdominal muscles to pull your rib cage close to your pelvis, and that causes a compressive load on the spine. So a roll up, in my mind, as my definition, is a loaded flexion exercise because you are creating a fairly significant, measurable at least, compressive load on those vertebrae. Now, for somebody with a, normal bone mineral density, it's completely and utterly safe and you could do a million roll-ups without a problem. But for someone with significantly lower bone density, it may or may not be a problem. And people may be doing those exercises for years and have osteoporosis that's undiagnosed. And then one day they get diagnosed and you have to tell them to stop doing those exercises they've been doing 3 times a week. And that seems a bit ridiculous. But the guidelines, current ACSM guidelines do say avoid end range loaded flexion or rotation. And so, that's what I would do if I were in your shoes. Avoid loaded movement. So in my definition, a loaded movement is anyone where you're working your abs to get into the position. So things like roll-ups, things like knee stretches round back, things like elephant where you're in a rounded position, all in my mind are loaded flexion exercises. Things that would count as not loaded flexion exercise would be something like cat stretch or say a gentle version of spine stretch forwards. Basically a stretch I would, class as okay. But something where you're basically working your abs, if you're going to work your abs in the position, I'm going to say, don't do it. So I'd say, flex your clients by all means, just don't, and load them by all means, but just don't do both of those things at the same time. So load them in neutral. If you want to stretch them, do some nice rotations and side bends and things at the end of class, mermaids, on the mat or whatever, that's great, but don't think of it as an ab work. Do it gentle and stretchy. And if you want to work their abs, just like if you've got someone with osteoporosis in your class, well, you can do a class where there's not loaded flexion, just teach a whole bunch of planks and side planks and, quadruped stuff on all fours. Like you can work people's abs like crazy without doing any flexion. So that would be my recommendation. As to the question about extension, I've heard that, they, quote, say it, but I haven't read it anywhere in a scientific paper. So I would say, Joe, that is one that is like, to me, if you're extending somebody, well, what are you doing? You're loading up the facet joints there. So it's like, well, wouldn't you expect to have more load on the facet joints? And if you wanted to avoid concentrating load on one part of the spine or another, probably just keep them in neutral would be my recommendation whilst loading. All right. Carly says, hi, Raf. I had a client say months ago she had a sore knee for several weeks after doing a movement which was just a side lying movement, bending and extending one leg up to the side. In other words, lying on your side doing like lifting the leg up, or maybe bending and straightening the leg up towards the ceiling. So that sounds like what I'd call a side leg lift or a développé maybe. And I thought, but how could you have a sore knee from a movement with no pressure or resistance apart from gravity on the working leg? Good question, Carly. Excellent question. She blamed it on not doing much exercise prior to the class, but I still felt like it was my fault in a way. Also, is there a limit to how many questions I can ask? Carly, there is no limit. In fact, Magda's asked 3 this week. I'm not sure I'm going to get to all of them because I have a time limit on how long I can spend on this, but I will get to them next week if I don't get to them this week. So this is actually a question you asked last week along with your other one, so I'm getting to it this week. All right, back to your question. Lady lying on her side, lifting her leg up, has pain in her knee, not your fault. Pain is not your fault. It's one of those situations where it's just the human condition. So if you're listening to this or watching this now, if you've ever had pain in your body, raise your hand. Hey, everybody listening to this is raising their hand right now because everyone gets pain. 9 times out of 10, we don't really know what causes it. It just comes for no apparent reason, goes for no apparent reason. Think headaches, think low back pain, think sore shoulder, think sore neck, think sore knee. You know, these things just come for no apparent reason, then go for no apparent reason. And so they're very poorly understood. So definitely not your fault. How could you have pain with no pressure? Really good question. Well, if your mental model, if your assumption is that pain indicates damage or wear and tear or excessive pressure on a joint, then that is a head scratcher. And I'd be thinking like, well, how the heck can you, there's virtually no pressure on the joints, like there's not even body weight on it. And that is why I would suggest that you update your mental model of what pain is. So pain is rather than thinking about pain as being an infallible indicator of tissue damage, I would encourage you to think of pain as being really just an output of the brain when the brain perceives too much threat, basically. Now, why do people get pain? Well, you know, this isn't an accurate physiological explanation of why people get pain, but it's I think a pretty good metaphor, and it's the cup of resilience. So imagine that you have a cup, and it's basically how much resilience that you have, and you can pour stuff into that cup because stuff always happens in life. Stuff that challenges your resilience. So like not getting enough sleep. So pour in a bit of not getting enough sleep. Okay, and then we might pour in a bit of financial stress. And then we might pour in a bit of relationship stress because you're fighting with your spouse because your financial stress is stressing you out. Then we might pour in a little bit of, a fight with your boss. Then we might pour in a little bit of low physical activity. Then we might pour in a little bit of not eating enough good food and having too many coffees. And basically, when you pour in too much, the cup overflows. And the overflow could often be pain. Sometimes it's other things like, when you get run down, when we get run down, typically each of us has a pretty familiar pattern about how, physical symptoms that we get when we run down. Like, so for me, I get a kind of crick in my shoulder where it joins my neck on the right side here. And when I get that, it just tells me like I haven't had enough sleep. I haven't been looking after myself well enough. And if I really get run down, I get kind of a sore throat. And it's not, I don't have a cold. I don't have any kind of, infection. It's just like I get a sore throat. And as soon as I have a good night's sleep, it goes away. And so I imagine for most of you listening to this, watching this, there's something similar for you. When you get run down, you have some particular sort of physical manifestation or set of sensations in your body that tell you it's like, oh yeah, I'm run down. And for some people that is pain, and so that could be the situation in her knee. And so the things that I would advise to alleviate that for her are, number one, just do more exercise. Try not to worry about it. Number two, think, ask her, have you been sleeping? Have you been looking after yourself? Have you been under a lot of pressure, lately? And often, the answer will be like, oh yeah, I haven't been sleeping that good. Sleep's a massive contributor to pain. So I would just suggest thinking about those things. And if you wanted to do a little experiment biomechanically, it might also, temporarily alleviate her symptoms if you just change the position of the leg. So if you literally just rotate the leg out a bit or rotate the leg in a bit or roll her hip back a bit or roll her hip forwards a bit, sometimes just changing the context, changing the physical position might move her away from what's called that sensitized position and allow her to be more comfortable in the movement. But it's not because her initial position was wrong and a new position's better. And there is no better position, but just a different position might be alleviating. Don't focus on it. Don't worry about it. Pain goes away much better when you focus on something else. Distract her, and distract yourself. So I hope that helps. I'm sorry there are a couple of questions I did not get to today just because I'm out of time, but I will get to those next week. Thank you so much for sending in your questions. I love to do research on this and that, and I'm learning a lot as we go along here too. And I hope you find these really helpful. And if you're a student, I'd love to hear from you. If you're a graduate, I'd love to hear from you. If you're neither a student nor a graduate of Breathe Education, I would love to hear from you. If you have questions, if you want to remain anonymous, you can. Just let me know when you email. You can email to AMA, that's Ask Me Anything, AMA@breathe.edu.au. And I will see you next week. Ciao.